Hi, everyone. Thanks for coming to our talk today. My name is Giovanni Rodriguez, and I'm an emergency medicine PGY3 and rising chief resident at the Harvard Affiliate Emergency Medicine Residency at MGH in Brigham.
And I'm Melanie Molina. I'm a clinical fellow in the National Clinician Scholars Program at UCSF, and we are going to be talking to you all today about racial and ethnic disparities in trainee evaluations. Unfortunately, neither of us have any relevant financial disclosures. Just to give you an outline of what we're going to be talking about. So we're going to walk through three major topics and then discuss some next steps. And those topics are going to be disparities in trainee demographics, disparities in trainee evaluations, and then potential causes of the observed disparities. So relative to the proportions in the general population, Black, Hispanic, and Native American physicians remain underrepresented in medicine, or UIM. So we're going to be using UIM to describe these populations, okay? And they experience significant disparities in career advancement, pay equity, and leadership achievement. So let's first talk about how these individuals are underrepresented by examining some racial and ethnic disparities in our trainee demographics. So this is a table that shows the percentage of self-identified race and ethnicity of U.S. medical school matriculants from 2014 to 2022. And while we can see an increase in UIM identifying matriculants over this time period, these increases are pretty small and remain lower than their respective percentages in the U.S. population. For example, for Black matriculants, we see an increase in the last decade from 6.9% to 10.2%, with a slight decrease from the last year, 2021 to 2022. For Hispanic matriculants, we see an upward trend from 9.1% to 12.3%. Furthermore, these numbers actually have become a bit stagnant over the last couple of years for both Black and Hispanic matriculants. And then we don't see much change in American Indian or Alaska Native students, with 1% for the last decade, and similarly for Native Hawaiian matriculants, there has been almost no change in the last decade. So although the number of matriculants into medical school has increased slightly, we see that the overall numbers in postgraduates from the year 2021 are still similar to those from 2008. Comparing the numbers from 2008 to those of 2021, we see the percentage of Hispanic identifying MDs increase slightly from 5.5% to 8.1%, but we do not see similar changes for Black identifying MDs, with 6.3% in 2008 compared to 6.1% in 2021. And the percentage of American Indian identifying MDs has remained approximately the same, for around 0.5% to 0.6%. So we know that Black, Hispanic, and Native American individuals are underrepresented among medical trainees, with slight, if any, improvement over time. And I'm going to turn it over to Dr. Rodriguez to discuss disparities in trainee evaluations, which have major implications for the recruitment and retention of a diverse workforce within our specialty.
Let's start with medical school. There's been studies that shown that there is a difference in assessments during medical education, with UIM students receiving lower clerkship grades. One study examined clerkship grades during medical school from 2010 to 2015, and they found that 4 out of 6 required third-year clerkships, there was a statistically significant grading disparity favoring white students over UIM students, even after they adjusted for potential confounders, such as student demographics, year, and Step 1 scores. Another study examined the data from 2013 to 2016 to determine if there were differences in grading and honor society memberships, as both can influence residency selection and academic career choices. The analysis included 670 students, with 26.4 being UIM, as defined by the AWAEM. They looked at the standardized exams given for each rotation, as well as the clinical performance. They found that on average, UIM students received slightly lower clerkship director ratings, which is important because these ratings were actually weighted more in their final grade than the shelf exam. And subsequently, half as many received honors in their clerkships. Because UIM students were less likely to receive honors in their clerkships, they were also less likely to be eligible for honor society memberships. Regarding the selection of students for AOA, an analysis of ERAS data from 2014 to 2015 that included 4,655 medical students found that even after controlling for Step 1 scores, research productivity, community service, leadership activity, and the Golden Honor Humanism Society, white students were 6 times more likely to be in AOA compared to Black students. This raised a concern for bias in the AOA selection committees. Regarding language used to describe students in the medical student performance evaluation, or MSPEs, for residency applications, one study noticed a significant difference in how white students were described when compared to Black students. Words like exceptional, best, outstanding were used for white applicants. And they also noticed that competent was used to describe Black students more than any other group. And this was in the category of ability. When they performed contextual analysis of these word uses, they found that they were less likely to have positive connotation than the term that they used. It was more of a term used for minimal assurance for the applicant. And the differences in word choices was also controlled for step 1 score, raising the possibility of bias as a potential explanation for these observed differences. And so here's the table that highlights the statistically significant differences. I think this kind of puts it more in perspective of just the different categories, and it's outstanding with like standout words, exceptional and outstanding. Black students were told 50%, whereas white students had a 64%, and that was statistically significant. In ability, students that were Black only had the competent usage 40% versus white students, which is 29%, and that was also statistically significant. With regard to graduate medical education, one recent article included 3,600 evaluations from 6 different internal medicine residency programs, and they found an association between race and competency scores, with lower scores being seen in UIM residents and the core competencies of medical knowledge, system-based practices, system-based learning and improvement, professionalism, and interpersonal and communication skills. And this is the graphic that visualizes that difference. Several competencies that truly stand out to me are the professionalism competency and also system-based, just how much different there was between URiM trainees, these are residents, and the non-white URiM trainees. And specifically the professionalism component, I'll touch more on this later on in the conversation because I think there's a lot more to discuss there when it comes to evaluations. Another intriguing finding is a particular study, and this same study was found an association between faculty sex and professionalism ratings, with male faculty rating UIM residents 0.13 points lower than non-UIM residents. Now let's talk about within emergency medicine, what are we seeing in our SLOs? That is concerning because the SLO was actually implemented to help reduce bias and standardize the evaluation of applicants. And in 2019, an analysis of approximately 3,500 SLOs revealed significant lower rankings on the rank against peer section for UIM students versus non-UIM students after controlling for gender, the interaction of race, ethnicity, class percentile, AOA status, type of school, affiliated program versus visiting clerkship, and also step 1 score. And non-UIM students were still significantly more likely to be ranked higher than UIM students. Similarly, UIM students had significantly lower rankings on the grades section for the SLO compared to their non-white UIM students. And so why are we seeing these disparities? What are potential causes that lead to this? And we were going to talk about potential causes from like 3 levels. 1, the trainee experience that includes daily microaggressions, mistreatment, racism from patients or colleagues, stereotype threat, and just minority tax and burden. Faculty bias, implicit bias, group bias, and then professionalism standards, and then structural racism, which involves access to educational opportunities from early on. So let's first start with the trainee experience. How does it differ between a UIM and non-UIM student? Qualitative and quantitative studies of medical students have found that all students have a low confidence in fairness of grading, with only 44% of students agreeing that assessments are fair. They also note that they felt that evaluations that were given by residents were actually more fair than those given by faculty, and about 33% of them felt that grading was biased. What's interesting that they bring up in this paper is the concept of stereotype threats. As defined on the slide here, for those that don't know, is a psychological phenomena in which members of negatively stereotyped groups worry that they will conform to their stereotypes, and a fear which impairs performance. And so when the applicants were asked, or the students were asked, about 20% of trainees indicated vulnerability. This was all students. When we specifically take out the URiM trainees, 55% of them reported feeling vulnerable to the stereotype threat. And so I want to break down more this figure that was in this paper by Bullock, what the stereotype is and how it affects performance. The study interviewed those 55% of students to ask them a little bit more to describe how the stereotype was a dynamic process and how it influenced their internal and external environment. And so it was not one static thing that just happened, but it was more of a three-stage process. So there's some trigger that affects the student, whether it's standing out, past experiences, something is triggering them on the basis of their race. They have an internal dialogue then about power dynamics, emotional impact. How do I respond to this? Am I supposed to respond to this? And then is the response. And then also on the bottom, they have a little bit about allies and how that people around you can either add to that stress or actually help. And so here's another example on how we implement and how it actually affects the trainee's ability. It starts with a negative experience, as I mentioned, such as microaggression or overt racism directed at the student. This then triggers a stress response and behavioral changes, issues with working memory, and then there's an impact in ability, difficulty demonstrating your competency, as all of these things are happening when you're either presenting a patient or actually talking to patients. And so another qualitative study of URiM residents actually cited additional burdens, the daily need to deal with microaggression from patients, not just from peers or faculty, both explicit and implicit, such as being confused for environmental services or individuals refusing their care, feeling the need to be the minority voice for their programs, but also responsible for addressing issues of disparate care provided to minority patients. They also describe this feeling of isolation or needing to fit in and form their own identity, as they're often labeled as othered, which heighten their awareness of their own appearance, including speech, body language, and also clothing. And so I have this little case here that comes back to that professionalism standards and how it differs between URiM and non-URiM students. And so professionalism, the lens through which different medical students are viewed, is very important, and the standard is different. I have this case here. There's two females on the screen, and they show up to your rotation. They're going to present a patient to you. And just think to yourself, do you see any difference here? Is one more professional than the other? What about now? Would you say one person's more professional than the other? And this was the reality of the case. A Black female wore a top that went to her shoulders, and the attending felt that it was inappropriate. Right after round, she pulled the med student aside and told her that the top was not professional, and quote, "You're here to care for patients, not to be fashionable," end quote. She was embarrassed. She tried every day to look well, and she was scolded for it, tried to fit the role of being a professional med student. Unlike her classmate who was wearing leggings, Uggs, a sweatband to patient encounters, and no remarks were made to her about her outfit. This scenario happened to my friend when I was in medical school. And it struck out to me because I witnessed firsthand the emotional distress that can come from these scenarios when they happen to students, and then now having to rethink every time, what outfit am I going to wear? Whatever I speak on or how I present my patient, is it not taken as seriously because of what I'm wearing to rotations? And it has nothing to do with her clinical knowledge at the moment of those comments. And so mistreatment can happen to all students, but we see that certain groups are targeted more than others. A national study of medical student mistreatment found differences in the prevalence of mistreatment by sex, race, ethnicity, and sexual orientation. Furthermore, URiM female medical students reported the highest prevalence of racial and ethnic discrimination. The differential treatment and non-inclusive learning environments, which could have profound implications for their well-being and academic success of students. This study reinforces the association between exposure to mistreatment and discrimination and decreased physical and mental health, worsening grades, lower academic motivation, and persistence. And moving away from the lived experience, we also want to talk about bias from the evaluators. Faculty members have exhibited the strongest measures of mistreatment and bias. Implicit bias in MDs was first reported in 2009 when implicit association testing for physicians showed that white physicians had a preference towards white individuals. That similar IAT was performed at a medical school admission committee, showing all groups, men, women, students, faculty, displayed a implicit white preference. Men and faculty had the largest bias measurements. 48% were conscious of their individual results when interviewing candidates in the next cycle, and 21% reported knowledge of their ITE results impacted their admissions decisions in the subsequent cycle. The class that matriculated following that IAT exercise was the most diverse in the medical school of history and their history of time. And recall the study I mentioned earlier where the residents were being evaluated and which male faculty were more likely to give lower points to URiM students. So there's also structural biases and inequities built into our system, such as the fact that only a certain number of individuals can get honors, which means only a certain can qualify for AOA. Furthermore, AOA selection committees often lack diversity in their committees, which can further perpetuate the lack of diversity in the societies. Structural inequalities also exist within our education system, with URiM students facing fewer educational opportunities due to lower socioeconomic status. Many of them are first-generation college students, and this results in a weaker pipeline to the medical school residency, from medical school to residency for URiM students. And so lower evaluation scores, how does this affect trainees? By decreasing their ability to get funding or awards, numerous studies have found evidence of racial and ethnic disparities with regard to the recipients of academic rewards in medicine. Black and Hispanic faculty members are less likely to be promoted in academic health centers, and Black faculty are less likely to be awarded national or NIH grants as compared to their white faculty. And this study came out last year. How does it affect EM, and what are we seeing in our EM faculty? Disparities in training evaluations, I think it trickles down to now looking at the rates of progression. In the last 30 years, females have shown progress towards equitable representation within academic emergency medicine, but there's been no meaningful progress made towards racial disparity. So, this slide, I recognize, is a lot of content, and I'd like to draw your attention to 3 specific areas which concisely summarize what we've been discussing. First, you have the trainee factors, which represent the unique challenges faced by URiM trainees. You then have faculty, resident, and rater factors, which could include commission of microaggressions and unconscious bias. Embedded within both of these spheres are cultural and structural factors, such as assigning a Spanish-speaking trainee to only Spanish-speaking patients that pervade both the trainee and the faculty experiences. All of them ultimately contribute to disparities in trainee evaluations, which lead to fewer career opportunities for URiM trainees. And now I'm going to hand it over to Dr. Molina to talk about next steps and what we do.
All right, so what can we do about this? So to reduce racial and ethnic disparities in trainee evaluations and trainee demographics, we can focus on change at 3 different levels. From a societal perspective, the data we presented today speaks volumes to the deep and structural nature of inequity that persists in the U.S. and how it influences medical training. Structural racism not only affects our URiM physicians on a daily basis, but also contributes to the decreased representation of URiM folks within EM and academia as a whole. We must first acknowledge this fact in order to begin to address it. More research is needed on how to uproot these pervasive effects, and this is unfortunately beyond the scope of our talk. From an institutional perspective, which is what we're going to focus on today, we've got to examine our departmental policies and workplace culture, paying close attention to racial inequities that exist within our departments and our residency training. We need to acknowledge that URiM trainees persevere through an educational system that does not work in their favor, and they encounter more challenges compared to their non-URiM counterparts, such as increased stress from microaggressions and stereotype threat. From an individual perspective, as evaluators of trainees, we must examine our own biases and mitigate these disparities in the form of equitable feedback, mentorship, and support of URiM trainees. So in order to successfully recruit UIM trainees, it is important to have an overarching diversity and inclusion strategic plan that is multimodal. And here are some examples of concrete actions that have been taken at other institutions as part of a larger plan with significant improvements in UIM recruitment. For example, the University of Pennsylvania Health System plan included visiting clerkships, explicit mentoring of junior faculty and trainees by a team of mentors, graduate medical education symposiums and workshops focused on topics within DEI, targeted outreach to specific candidates, and dedicated DEI-focused interview days. These changes resulted in an increase in their diversity over a 7-year span from 8 to 23%. Similarly, at Massachusetts General Hospital, through the Diversity Office, they created special recruitment sessions for UIM trainees, implemented housing stipends, and developed a career mentoring/coaching program for UIM residents. In the last 3 years, they've seen an increase from 15 to 25% in their diversity. The emergency medicine residency specifically has focused on UIM targeted outreach to specific candidates and the creation of DEI-focused interview days, socials, and second looks. Other opportunities to decrease implicit biases and microaggressions at the institutional levels are to require implicit bias and upstander training for all employees. For those faculty in the audience, we encourage you to examine your own biases when providing feedback and evaluations, and consider becoming an active bystander for your trainees when they experience microaggressions on shift or otherwise. All right, so what are our take-home points? First, we recognize that there are disparities that exist in trainee demographics and trainee evaluations which disfavor UIM trainees. As a consequence, UIM trainees have decreased career advancement opportunities, leading to a dearth of UIM clinicians in leadership, research, and academia. Some potential causes of these disparities include trainee experience, such as daily microaggressions, mistreatment, racism from patients, stereotype threat, etc. Faculty bias, which includes implicit bias, group bias, specifically regarding professionalism standards, and structural racism, which include educational inequalities and qualification standards, such as the example we gave about the AOA. All right, thank you for our talk, and we hope to answer any questions the audience has.
I was wondering in any of the literature review that you did, or even talking to some of your colleagues, if you came across anything that talked about at the trainee level a cultural influence in that, or maybe something related to the stereotypes that the trainees are worried about, in that would our UIM trainees be afraid to stand out, either in a positive way or feeling like they couldn't make a mistake because it wasn't a safe environment? Because maybe they wouldn't be recognized enough for being positive, or they'd be punished more for giving the wrong answer. I was wondering if you came across anything like that.
Yeah, the article actually by Bullock, Justin Bullock, it describes more, and it's more like qualitative. They're like talking about the interviews of like what they feel when they're presenting, whether they're saying the right thing, the words that they're using, the code switch of like, I might speak a certain way, but when I'm presenting, I have to make sure I speak differently. There's definitely a lot more on that. I'd suggest reading that. It really goes more into like examples of like quotes of what the students are actually feeling. From a trainee experience, I feel like we have the mistreatment one where it was more showing that women felt like they were more mistreated, the way you wear your hair, like what clothes you wear, because it's definitely not as easy to look as professional. Like, you know, the spectrum of professionalism for a woman's outfits is a little bit different to like men. They can just wear a tie and call it a day. And so they talk a little bit more about that in that paper too.
I'm wondering what advice you have. So I'm the director of equity and inclusion for my department, and we've really been trying to implement a lot of these DEI initiatives across like multiple domains in the department. And one of the things that makes me a little bit uncomfortable is thinking about all of the things that I know my UIM trainees are going to experience / probably have experienced in their training, and this idea of increasing representation in a setting that has been very kind of violent and harmful toward those people. So I'm wondering if you've come across in your literature review or your personal experience and how to make that environment less violent toward these people that we're trying to increase
Yeah, no, that is an excellent question that I have. I'm also on the GME board at my hospital, and I'm also the chair for the diversity office as a student, or like as a resident, I'm not a student, I'm representing. But that's a great question, because I always pose the question, we can recruit, but what are we going to do to retain? Like, we can't just recruit people. Like, I tell that to like all the applicants. Like, we have these sessions with faculty and actually trainees that's ended up staying in their faculty now, that have had a good experience, and share that. And so that's one way, like if the place where we're training actually is good, then I'm going to recruit you and like tell you, like, I wouldn't bring you here. And actually, I have like my junior residents talk to them, like, I would not recruit you here if I didn't think it was a safe space for you. And so that's one way. But now if this place is not well, then that's something we need to talk about. And how do we increase our knowledge, our competencies? And so I work with one of my co-residents, Dr. Carreras, who's about to graduate. She started a health equity curriculum that we actually implemented during M&M. So every time we have M&M once a month, we have 30 minutes where we talk about these cultural competencies. And it's a spectrum of not only patient-provider, but also for our colleagues, the provider experience. We talk about microaggressions. We talk about how to be a good ally. And so I think that has led our department to actually be more outspoken. And Dr. Molina was there before me, and there's been so much change, and just talking about it and not saying, oh, things are okay and put in a Band-Aid, but like truly have those uncomfortable discussions with your team members, with your department leadership.
Yeah, just to add to that, the health equity curriculum that Dr. Rodriguez mentioned is like the version 2.0. So when we were there, we started a brief health equity retreat, and we actually had like a 3-hour retreat, basically, which was like involved like a panel, basically giving kind of like trauma-informed care, but also a practice session on like microaggressions, confronting microaggressions, and then playing out role-playing scenarios about how to kind of respond to microaggressions. And then importantly, when we like publicized, we got our chairs buy-in, and so both of the department chairs at both of our sites attended, and so having the chairs attend ensured that it kind of was well attended by other faculty members of the department, so it wasn't just like you were preaching to the choir. And we had quotes of microaggressions that our residents had actually experienced, read by people around the room that we kind of hand chose to read. And it was really impactful and kind of started these kind of uncomfortable conversations, but also created a safe space. And then I think that's kind of the first step, is like being willing to have those conversations, and also kind of then ensure that you have like that safe space for your trainees who do experience those expressions of violence on shift, to be able to come back and feel free to voice that concern. And then the other thing that at MGH, we had the Office of Diversity, which actually just creates a community of folks across specialties. And so I know that Dr. Rodriguez is very close with all of the members, which is interdisciplinary, of URiM folks across the entire hospital and MGB system. And that really helps to have like a community where you can come back and say, hey, like this happened, like what did you guys do about it? Or just like have that support to kind of lean on. So I think those things are really important. Yes, right here.
Well, I wanted to thank you both for this presentation. And obviously, from personal experience, I know that being a third-year medical student on the ward is a very difficult and traumatic experience, particularly for someone that identifies as a Black woman, when just the very nature of the manner that your hair grows out of your head is considered unprofessional. I think that you guys talk a lot about training physicians, medical students, et cetera, but I'm coming from Emory, and one of the things that we talk about is like a cultural change. In addition to some of the microaggressions that we can control, are there any things that you guys are doing at your institution to make sure that nurses, paramedics, and et cetera, because they also, of course, are the cause of the recipients being on the receiving end of a lot of these microaggressions. For instance, a nurse before. And I'll have to stop you and say, no, I'm the attending physician, you can address me as well as everyone else in the room. So I'm wondering, are there things at your institution or things that you guys have come across or that we can do to educate some of our support staff, our nurses, et cetera, who also contribute to this environment of like microaggressions and toxicity?
I mean, I think Dr. Molina was mentioning that retreat that we used to have, that was just a lot of microaggression conversations, but we also give them skills. We partner up with Cricket, who is an internal medicine doctor that gives this really great toolkit of how do you become an ally and what are the things that you can do. And within that, we give that to the attendings. Things like I think they're really good in our department. If I come in and someone starts addressing, usually the white male, they always say oh no, the person in charge is Dr. Rodriguez. And so it's making sure that that's happening. Also introducing myself as doctor. And so I know a lot of white men were oh, my name's Tom, and that's just how it goes. They specifically, and all our residents started doing that. Everyone's introduced as doctor. That way, the patient doesn't say just your first name or think that you're someone else. It's very explicit, told. And a lot of that came out of those workshops of training the attendings.
Yeah, in terms of explicitly answering your question, I don't know of anything formalized at my own institution and at Harvard that addresses EMS bias. But what we did do was implement simulation, kind of racial bias and de-escalation training for the nurses that was interdisciplinary, so it included the nurses as well as the MAs, or what are they called?
So it was our ESAs, our tech supports, our coordinators,
Yeah.
our nurses,
And then our
faculty.
physician assistants, residents, and attendings, and it was an interdisciplinary team where we had a simulated scenario in our sim center with real patient actors, basically because we noticed that there were bias in physical restraint use. And we touched on a lot. We gave that was specifically for physical restraint use because we found that our nurses were calling for security and restraint on our patients of color more than our white patients. But we gave the same kind of didactic to our nurses and the support staff and all of the other interdisciplinary team members before we went into the sim center, which was basically a similar version of the microaggressions talk that we gave to our residents, which I found to be very helpful. But I think that would be an area to explore for sure, because these things happen from not just our colleagues, obviously, from all of our other staff as well. You had a question?
Again, you guys brought up great points, all the things that, we need to do to change the culture and, every entity trying to get training for every level. But one of the things I was going to bring up that we do at our institution, we've been going 3 years, so we'll be able to look at the data coming up, is we have now on our evaluations, at the end, you have to check a box that says, I have filled out this evaluation, aware of thinking about my implicit biases during this evaluation. And so not only their training that everyone has to go through in order to, this for our residents, to actually evaluate any of our residents, but then at the end of the evaluation, they have this click box to sort of remind them to think about what you wrote. And, some of the stuff we have now just from our focus groups is a lot of them are they're, when they got to the end of the evaluation, they go back and look and go, ooh, maybe I shouldn't have written that, or maybe I didn't write that, so we'll be able to compare and see what some of those look like.
That's awesome. That's a perfect, and easily something that could be added or scaled. So that's great. I'll be looking for the results of that one.
Awesome.
Any other questions? Thank you guys so much.
Thank you.